let's ask Naim Alkhouri to join us from down in sunny Phoenix. He's going to talk to us a little bit about the pharmacological approach to patients with MASLD, and as the guy who is the head of the liver transplant program down there, I'm guessing that you're not looking for more business, so let's start treating urgently. Turn it over to you for your wisdom around pharmacological interventions.
Thank you very much for having me. Can you hear me okay?
Loud and clear.
Okay. Yeah, no, thank you, Eric, and thank you, Mike, also for organizing this lovely webinar. It's really an honor to be with you guys. And my goal over the next few minutes is to give you a flavor of available pharmacologic interventions that we have today and tell you about how to select the appropriate patients. So first, I want to start by saying that 2024 was a historic year for us in the MASH field. We witnessed the first FDA approval of the first drug, Resmetirom. That was on March 14, 2024. So this has been something that we are able to do in the United States for our patients with MASH and F2, F3 fibrosis. So again, the indication is for what we call significant fibrosis. This medicine is not indicated for patients with F0, F1. It's also not indicated for patients with cirrhosis. So very targeted patient population. A few days ago, we also heard the results of the Essence phase 3 trial with semaglutide. This is the GLP-1 that had indications for type 2 diabetes and obesity for the past few years. And based on this phase 3, we may actually see FDA approval next year. And I have a new mantra in 2024 about treating patients with MASLD and MASH, which is just do something. And the do something is the 3 S's. The first S is to screen high-risk populations like patients with type 2 diabetes and metabolic syndrome in primary care and endocrinology offices. And then once we identify MASLD, the most important step is to stage their disease and know if they have significant fibrosis, because we can treat them with lifestyle intervention. And recently now we have pharmacologic treatments. And then finally, the third S is to start treatment once we identify patients with what we call at-risk MASH, MASH with F2, F3 fibrosis. So again, the target population for the treatment is, these patients with F2, F3, and MASH. The new name is at-risk MASH. On a liver biopsy, we do something called the activity score, where we give a score to steatosis, inflammation, and ballooning. And typically, at least in clinical trials, we require activity score of 4 points or higher, plus F2, F3 fibrosis. And again, identifying these patients is key, because they are the ones that will benefit from pharmacologic treatment. Now, how can we identify the presence of significant fibrosis? We have several tests that are available to us here in the United States and in Canada. One is the Enhanced Liver Fibrosis Test. This is a blood test, and it has 3 biomarkers of liver fibrosis. This includes hyaluronic acid, procollagen 3, and TIMP1. Basically, you take a blood draw, and then you're going to get an ELF score based on the equation shown on the slide. And then you get your score, and the score more than 9.8 typically indicates F3 fibrosis or higher. And we've learned recently that maybe a cut point of 9.2 will indicate the presence of F2 or higher. So what you see now in some of the new guidelines, how to select patients with significant fibrosis based on ELF, we use an ELF of 9.2 or higher. We also have several imaging tests based on ultrasound and MR elastography that you heard about already. And the one we utilize the most is transient elastography. That can be done with the FibroScan machine and other machines. So we have several ways that we can identify these patients with MASH, F2 fibrosis or higher without needing a liver biopsy. And when drugs are being developed, the FDA gave us 2 primary endpoints to get a medication to what we call accelerated approval. On the repeat liver biopsy, after you start treatment, you need to show either MASH resolution, so again, a significant reduction in disease activity, or fibrosis improvement by one stage. So if you start with F3, then on the second liver biopsy, you need to be at F2 to be called a responder. So these are the main primary endpoints for accelerated drug approvals. So first, I want to share some data on semaglutide, show you some promising results from the Essence phase 3 trial. As I mentioned earlier, this was presented at the last ASLD meeting in San Diego. And this is the trial design. So patients were randomized either to placebo or semaglutide, the obesity dose, which is 2.4 milligrams weekly after standard dose escalation. They had a biopsy at baseline that showed that they have MASH with F2, F3 fibrosis and active disease. And then they were treated for 72 weeks, had a repeat liver biopsy. And we looked at the primary endpoints of MASH resolution and fibrosis regression. These are the baseline characteristics of the patients in the Essence trial. So typically middle-aged adults, about 50-50 male, female, high percentage of diabetics, 55%. Importantly, about two-thirds of patients had stage 3 fibrosis, so more advanced disease. And then we have also the data from transient elastography, VCTE. So this will help us, to select these patients for treatment. So the mean transient elastography on FibroScan was around 12.8. And then we also have the mean for the ELF score. And in this study, it was around 10. And remember, I said 9.2 is when you start seeing the F2 fibrosis. More than 9.8 is consistent with F3. And the majority of patients in this trial had F3 fibrosis. And this is the primary endpoint slide. And in the Essence trial, semaglutide achieved both primary endpoints. So on the MASH resolution, you can see that the response rate was close to 63% in the semaglutide arm compared to 34% in placebo. So the delta was around 29%. This is what we call estimated difference in responder proportions, or EDP. That means that this is the absolute risk reduction. So the number needed to treat to achieve MASH resolution in one patient is basically 1 divided by 0.3, which is around 3 patients. Importantly, also, semaglutide achieved the fibrosis endpoint, fibrosis improvement by one stage, and this was achieved in 37% of patients treated with semaglutide versus 22.5% in the placebo arm, and that delta was around 14.5, which means that the number needed to treat to achieve that fibrosis improvement was around 7 patients. And keep in mind, this was 72 weeks of treatment. So both of these endpoints were statistically significant. So this is very good news for our patients, and we suspect that semaglutide will potentially become FDA approved next year. We also looked at other endpoints, including change in body weight, and as expected, you see significant reduction in weight with semaglutide. There was also about one-third of patients that achieved both MASH resolution and fibrosis improvement. Importantly, also, there was improvement in quality of life measures with improvement in quality of life in the semaglutide arm. Semaglutide was also associated with improvement in liver enzymes, ALT, AST, and gamma GT. And there was also change in the non-invasive tests. So there was reduction in liver stiffness, VCTE. There was reduction in the ELF score and other fibrosis biomarkers. So it wasn't just, histologic improvement. It was biochemical improvement and also liver fibrosis improvement on NITs. So Resmetirom has been approved now for about 7 months or so, and it's been really a good journey for us in the United States to be able to prescribe this medicine for patients with F2, F3 fibrosis. The accelerated approval was based on the Maestro-NASH trial, where patients were randomized to 2 doses of Resmetirom, 80 or 100 milligrams versus placebo. Everyone had a biopsy at baseline showing MASH with fibrosis, a repeat biopsy at 52 weeks, and this is where we analyzed the 2 endpoints of MASH resolution, fibrosis improvement. And these are the baseline characteristics in the Maestro-NASH, very similar to what we saw in the Essence trial. So about two-thirds had F3 fibrosis, and the median transient elastography was at 12, and the median ELF was at 9.7. And I keep showing you how, these NITs are being incorporated in clinical trials and in clinical practice, and you can see that the thresholds are very similar. This is the primary endpoint in the Maestro-NASH trial, looking at NASH resolution. And you can see with the high dose, 100 milligrams daily of resmetirom, that was achieved in 30% versus 10% in placebo. So the delta is 20%. But keep in mind, this was only 52 weeks versus 72 weeks with semaglutide. And then when we looked at fibrosis improvement by one stage, it was 26% with high dose resmetirom versus 14% in placebo with the delta of 12%. So also both statistically significant and very encouraging. So what we think is going to happen in 2025, at least in the United States, is that we're going to have this big fight between resmetirom and semaglutide, and we need to decide which medicine is best for our patient. And I suspect that in a significant percentage of patients, we will potentially use both medications because they have potential synergy. So first, I want to show you this document that I published with Dr. Nuruddin and other colleagues, trying to help practitioners to identify appropriate patients for treatment with resmetirom. And based on the data from the Essence trial, I think the same thresholds will be true to identify patients for treatment with semaglutide for the MASH indication. So we divided the patients based on non-invasive tests into three zones. The green zone is, the sweet spot where the patient should be definitely treated with resmetirom or semaglutide. These are patients with transient elastography between 10 to 15 kilopascal, suggestive of F2, F3 fibrosis and no cirrhosis. You can also use MR elastography between 3.3 to 4.2 or ELF score between 9.2 to 10.4. And then we have the yellow zone. These are patients that you should consider treatment, but some of them may have cirrhosis. So you have to be careful to rule out cirrhosis. And these are patients with transient elastography between 15 to 20, MR elastography between 4.3 to 5, and ELF between 10.5 to 11.3. And then we have the red zone. These are the patients that you should not treat with resmetirom or semaglutide for the MASH indication. These are patients with transient elastography more than 20 kilopascal, MR elastography more than 5, and ELF more than 11.3. And this is what we do in our clinics now. We utilize these criteria to decide on treatment. If you're in the yellow zone, before you treat, make sure that the patients have normal platelet count and make sure that you obtain a full abdomen ultrasound, making sure the liver is smooth and that there is no splenomegaly. If in doubt and you think the patient has cirrhosis, don't treat. But you're going to have a lot of patients that will qualify for treatment that are in the yellow zone. So I want to show you a couple scenarios how we will select treatments next year. So fight number one will be won by semaglutide. This is a 53-year-old male with past medical history of hypertension, obstructive sleep apnea, knee osteoarthritis, and there was a recent paper showing improvement in pain in these patients with semaglutide. So multiple comorbidities, also, severe obesity, BMI of 39.2. So this is class 2 obesity. Comes with hepatosplenomegaly, fatty infiltration of the liver, and the FibroScan shows liver stiffness of 11.6 kilopascal, consistent with significant fibrosis with significant steatosis. And this patient, I may select to start semaglutide first because of the beneficial effects on obstructive sleep apnea, the weight loss, the knee osteoarthritis. Treat them for a year and then repeat the FibroScan. And if we see significant improvement, then maybe just stay on semaglutide. If the liver stiffness does not budge and in a year it's at 12 kilopascal, then I would add the resmetirom on top of the semaglutide. Fight number two will be won by resmetirom, in my opinion. This is a 56-year-old Hispanic female with past medical history of type 2 diabetes for the past 12 years, and she's been on another GLP-1 agonist for the past 5 years. Her weight is in the overweight range, 26.6, and her A1C is actually well controlled for someone with type 2 diabetes at 6.4. FibroScan shows liver stiffness of 12.3 and significant steatosis. This patient who has diabetes that's under control, overweight only, not even obese, has been on a different GLP-1 for the past 5 years. I think probably starting with, Resmetirom will be my choice because I doubt she's going to see great benefits from just switching to semaglutide. And in the last few slides, I just want to share some data about some future promising agents. These are data that were presented at the last liver meeting. Some of them were continuation of ongoing trials. The first medicine I want to mention is called efruxifermin. This is a hormone we call FGF21. It stands for fibroblast growth factor 21. And these are the results from the Harmony phase 2b trial. This was a study where patients were randomized to placebo or two doses of efruxifermin. The high dose was 50 milligrams. This is an injection once a week. Everyone had biopsy with MASH and fibrosis, and they looked after 96 weeks, so almost 2 years of treatment, at the rates of improvement in fibrosis. And this was very encouraging. I wanted to focus on the 50 milligram dose in the dark blue. When you compare to the placebo arm, you can see that with efruxifermin, up to 75% of patients had fibrosis regression by one stage. So this is really remarkable and very encouraging to see this high rate of fibrosis regression. We also looked at the ELF score for fibrosis, liver stiffness on FibroScan, and both of them decreased significantly by 96 weeks of treatment. We also looked at response in all three markers. So fibrosis on biopsy, liver stiffness on FibroScan, and ELF on the blood test. And you can see in the placebo arm, none of the patients achieve improvement in all three markers. Whereas if you look at the efruxifermin 50 milligram dose, up to 42% achieve improvement in all three markers. So either the biopsy improved, the biopsy improved, the ELF score improved, and the liver stiffness improved. And actually, there was 0 patients that had improvement on none of them. So this is very encouraging. We're getting to a point that we may be able to reverse the disease, hopefully. And then finally, I want to show you some data with the promising new agent called survodutide. This is a dual agonist GLP-1 and glucagon. We've known that GLP-1s have many beneficial effects in patients with MASLD. They're mediated with weight loss, so it's indirect effects on the liver, but they help with insulin sensitization, and they delay gastric emptying and induce satiety in the brain. Adding the glucagon piece may have additional beneficial effects on the adipose tissue, but also it has direct effects on the liver, so it can enhance fatty acid oxidation and improve glucose control in the liver. So this is, again, a dual agonist called survodutide. And this was a phase 2b trial that has been published now in the New England Journal of Medicine, where patients were randomized to 3 different doses of survodutide with the dose escalation that took 24 weeks versus placebo. Everyone was treated for 48 weeks. And what we showed here in this trial is that up to 83% of patients treated with survodutide showed improvement in MASH activity, and this was significantly better than placebo. You can see very big delta between 83% and 18%. And then we also have data on reduction in liver fat. So when you look at a threshold of 30% relative reduction from baseline, up to 87% of patients on survodutide achieved this. Even when you look at improvement by 70% reduction, which is a very high bar, about 50% of patients on survodutide achieved this, and this was achieved in 0% in the placebo arm. So very potent agent with very targeted liver effects. At the liver meeting in San Diego, there was more data presented on reduction in liver stiffness by transient elastography, showing the survodutide arms showing much higher improvement. There was also data presented by Dr. Nordin on the ELF score coming down with the treatment with survodutide. So it's looking really good for our patients, and this is my take-home message that we had a great 2024. We have the first drug approved, and I think 2025 is going to be another amazing year in MASH for our patients. I think both semaglutide and resmetirom will have the indication for at-risk MASH, which is MASH with F2, F3 fibrosis, and the treatment decision should be personalized based on the following factors. Number one is disease stage. Are we talking about early F2 versus late F3? Number two is the comorbidities. Does the patient have severe obesity, uncontrolled diabetes, dyslipidemia? We need to take this into account. And then exposure to previous medications. If the patient has been on a GLP-1 in the past, clearly maybe resmetirom will be a nice addition. And then we also have to take into account patient preferences and their experience. And if someone does not want to do an injection, that's very important to keep in mind. I do believe that combination therapy will be beneficial in some patients that need more than one drug, and I do believe that there will be some synergy between semaglutide and resmetirom. And I suspect that we start with one agent, but if we don't achieve the desired response after 1 year of treatment, there will be room to add a second agent. Finally, we have a few expected readouts of phase 2 trials in patients with cirrhosis. So NASH cirrhosis, this is really the highest unmet need and the highest bar to show improvement. So these are patients with stage 4 fibrosis, and we have three exciting therapeutic targets. One is called belapectin with Galectin Pharma, and they're in phase 2b trial. We also have a combination regimen with Gilead that should read out next year. And finally, we have data with efruxifermin, the drug I showed you earlier, but this is looking at cirrhotics that were treated for 96 weeks. So very exciting developments, and really it's been a nice journey for me starting in this field back in 2008, having no pathway for FDA approval. And then when the FDA gave us, the path to get drugs approved, it took us a decade before we had the first one approved. But this is really a very different landscape that we're in. And we suspect that, within the next 5, 6 years, we may have 3 or 4 drugs to choose from. And this is very good for our patients. So with this, I'm going to conclude. Thank you for your attention and the opportunity to present. And this is my last slide, I guess. Just do something. Don't forget to do something for patients with MASLD and MASH.